Hi, so this week I've been chatting about Achilles tendon problems, and the other day we did a video looking at what had happened in an acute Achilles problem and how best to manage that. So really what we want to look at today is what will happen if you have like a persistent Achilles tendon issue, one that sort of might be termed as chronic, it's been going on for a long time, coming and going. What do you have to do? What's the best way to get this sorted out, and what are your treatment options, and sort of where do these treatment options fill in a treatment hierarchy, if you like? So I think the first thing you've got to look at is if you've had like a persistent Achilles problem, is number one is we need it to assess to find out what kind of Achilles problem we're dealing with, and also what's sort of driving it. What are the main factors that are causing this problem for you? So obviously we want to divide it up in, is it a mid-body Achilles tendon problem? Or is it an insertional Achilles tendon problem? Or do we have something else going on, say like the bursa that sits in behind the tendon there that's getting really aggravated? Or is there something else actually generating that kind of pain? Because we do have the sural nerve and the long saphenous nerve that can create pain at the back of the leg that is similar to the pattern that sometimes an Achilles will present with. It's rare, but it does happen. So I think number one, it's really important to differentiate what type of problem we've got, what structures are involved, and then from there we can work out where we go. So the first thing that I probably want to have a look at is this a loading problem? So is it an ability of that tendon to tolerate load? Or is it a biomechanical problem? So is it actually something wrong with how the foot moves, or not so much wrong, but how an abnormality in the foot movement that's maybe driving this problem? Chances are it's going to be a combination of both of these, but we've got to find out which is the number one, what's our priority. So when it comes to biomechanics, things we want to look at is we just tend to find out, look, how does the big toe move relevant to the midfoot? How does the midfoot move? So has it got enough what we call pronation and supination? How the ankle works, has it got enough sort of dorsiflexion, so can it bend up? Can you flex it down? And even at the back of the Achilles here, the subtalar joint, if that's got the right amount of movement too. So those can be issues that we need to go and have a look at, and quite often even in the clinic we can sort of maybe just try some taping to restore or just correct that movement. And if that certainly eases off your Achilles problem, then we may have more of a biomechanical issue driving it, and that might be something that we refer you on to our friends up at Dynamic Podiatry to have a look at. The other thing we want to have a look at is it a loading response? So what do I mean by that? I mean, what a loading response is how that tendon is adapting to activity. The most common problem that we'll see when it comes to loading is people starting a running program or walking from doing very, very little and just jumping in at the deep end. And you've got this poor deconditioned tendon that then we're asking way, way too much of to do, and then it becomes quite reactive and sore. So if there's a loading issue there, number one, what we have to do is we have to try and address that to get it back to just the right amount, so you're getting the exercise you want, so you're still generally getting healthier and the tissue's getting healthier, but without aggravating it and stirring it up. From there, what are our treatment options? Well, I've already said biomechanics can be one thing we look at, and that's I tend to send to the podiatrist to have a look at from there. Number two, the loading issue. So if there is a loading issue, it tends to be that this structure here and the movements don't have the strength and endurance to cope with what you're asking them to do. So looking at the muscle strength of the calf complex, so that obviously your gastrocnemius and your soleus, also having a look at the strength of the lower limb and what it's doing, and even the core, if these can meet the demands that you're asking of it. And then what we can do from there is we can design a really good exercise-based program that will not only get that area stronger, but will also help reduce the pain around about the tendon, and more importantly, will prevent or significantly reduce the chances of this happening again. So these loading programs are really important, and I'll talk to those in another day, and I've got a couple of blogs on what are really successful and how to do the exercises. If that's not really getting you to where you want to be, what are the options after that? Well, for the more recurrent, sort of recalcitrant, if you like, tendon problems, my first sort of point of view from there is if the loading's not working and the biomechanics isn't changing it the way we want to or as quickly as we'd like to, shockwave therapy can be really useful to help dampen down the symptoms there and really sort of kickstart that healing repair process. And usually that takes over sort of maybe about 4 to 6 sessions to get you going. It's always done in conjunction with an exercise program, sometimes done in conjunction with exercise and like manual therapy to the foot to get that moving better. But it's part of your program, it tends not to be the whole story. If that's not going on from there, then there are other options that are sort of towards the end of the treatment hierarchy. They try and avoid tendon injections as much as possible because it does tend to weaken the tendon, but that sometimes can be indicated in cases that really aren't moving forwards, and if people have been putting in their time with the rehab and it's not changing. And those injections sort of can take the form of what's known as PRP, sometimes prolotherapy, sometimes cortisone, but not often these days. But that's really for a very sort of small and sort of a smaller group of people, and hopefully it's not something we have to look at. So that's how you treat your tendon. That's what we're looking at. So it's really getting it assessed, find out what the problem is, what the actual structure is that's causing the problem, make sure the biomechanics aren't driving it, make sure you're not overloading it, and then starting to reload it to get that tendon strong again. Because rest isn't going to make it better, and it's not going to get it to clear away in the long term. And a lot of your treatment should be based about fixing you up for the long term. I hope that's useful. I will put a link to a blog on injections and also one on why we do the loading programs, and we'll start showing you the exercises for the Achilles tendon. I hope you find that useful, and I'll speak to you soon. Bye-bye.